Currently, she serves on the Committee for Leadership Succession for Sigma, and she is also the Research Committee Chair for the chapter, Omega Kappa chapter. She has been involved in nursing education. She has done publications in several journals, and some of the areas are in chronic diseases, professionalism, teaching and learning. And so Mrs. Anderson Johnson is well suited to present to us this afternoon what is evidence-based practice. Please make her welcome. Please unmute Mrs. Anderson Johnson.
Thank you. Good afternoon, everyone, and thank you for giving me this opportunity to share. Mrs. Garrix-Lloyd, thank you so much. All right, so today I'm just going to get right into it because I know we don't have a lot of time. And I have 15 minutes to make a presentation on what evidence-based practice is. And believe me, in February of this year, I attended a immersion workshop, and Dr. Cindy Beckett was one of the presenters there as well. 5 days where we were taught about evidence-based practice. And here I have 15 minutes to present. So you can imagine that it will be very summarized, and there are many more areas for you to learn about evidence-based practice. I'm going to try and do so. All right, so what are the areas that I would really like to focus on today? I want you to leave understanding why it is important to have evidence-based practice implemented in your organization, whether it is clinical setting or it is the academia. What is evidence-based practice? Talk about the process, the steps, different models, and then I will end in just a brief mention of the best practice guidelines, how they connect to evidence-based practice, and which will be a good segue for Ms. Brown to make her presentation. Okay, so those are the objectives. Now, when we look at the historical development of evidence-based practice, we start from 1972 when Dr. Cochrane out of the UK highlighted how important it is to test for effectiveness of healthcare strategies. And he highlighted the importance of using randomized controlled trials in determining what the best practices were. So this development and conversation continues into the 1990s, and in 1992, the recognition by Guyot et al. Introducing the term evidence-based medicine, right? So then it was really a shift from using intuition and tradition and moving more into that scientific research in caring for patients. In 1996, though, Sackett et al. Out of Canada further explained what evidence-based practice is, in that it was not only research evidence, right? But it also should take into consideration the clinician's experience and the patient's preferences and values, right? So it was during this time then, the 1990s, that evidence-based practice started to spread across all the disciplines. And in the 1990s, it became a part of nursing. And some of us may have heard about research utilization. That was a term that was common in the 90s, right? Where nursing would be using that. But evidence-based practice is wider. It's more than research utilization, okay? And so here we are actually using evidence-based practice. I want to create some context because we are here in Jamaica, right? And so in Jamaica, we have increasing nurse migration. There's often negative media coverage, which is related to patient dissatisfaction in a number of hospital settings and healthcare settings, staff jobs dissatisfaction, and of course, in the past a year and a half, we've been experiencing the COVID-19 pandemic, which is worldwide, of course. So why evidence-based practice? So it has been shown to be very effective and more persons are using it. It has been described as it is a simple message of care to patients and practice that is based on current, valid, and reliable evidence. And that's according to Trindo, right? Further, it has been shown, and there are a number of studies that have shown that it improves patient care quality, right? When it is successfully implemented. Additional benefits include nurses' job satisfaction, increased nurses' job satisfaction, patient satisfaction, cost saving for the organization, and improvement in the interprofessional relationships. So these are some of the other benefits of evidence-based practice. It has been shown by Riley and Melnick that highly reliable organizations, these are some of the attributes. They conduct transdisciplinary team training, they deliberately design key care processes, ensure that the team understands these processes. They're error-proof. They error-proof their organization. There's process standardization, and also they cultivate a culture of evidence-based practice. That's what I want you to focus on. Further, when we talk about patient safety, and if we really want to develop patient safety, develop a culture of patient safety, what are the components that are very important and that we should focus on? And see right in the middle of that is evidence-based practices. Leadership, teamwork, communication, having a learning culture, a just culture, and is patient-centered. Also, they have evidence-based practices implemented as well. Let's go now to define what evidence-based practice is and some of the tenets of evidence-based practice. So evidence-based practice is known as a problem-solving approach to the delivery of quality patient care. We have other problem-solving approaches, but this one is used in the delivery of patient care, quality patient care. I want to say that it rests on three main tenets, right? And here I have presented it as a stool, you know, those three-legged stools, the three legs. And the three legs are the best scientific evidence, so that is from research. And the best evidence doesn't mean that it has to be a randomized controlled trial, right? We use different types of studies to come up with the best available evidence. Clinical expertise or experience, so that could include our expert panels, our practice groups, consensus statements that are provided through these groups, and you and I, the clinicians in the areas, our expertise, our experiences. Not only that, the patient's preferences and values, you know, their level of satisfaction, that will affect their quality of life, the treatment burden. So we can use an example of chemotherapy. You and I will know that this is the best treatment for the patient. It is shown through the research, but the patient is unwilling to go through the side effects and so on. We have to respect that. And we have to, our religion, their own culture may affect their acceptance of what we are providing for them as well. Okay, evidence-based practice. I want us to leave with this message that when we are trying to create a culture of evidence-based practice, we must remember that it is walking the talk, walking the walk, talking the talk. We have to, it is a part of us. It becomes a part of our DNA, right? It's not just something that we have and today we can put it down and tomorrow we take it up and so on. It is a part of us. And we have to remember that if we want evidence-based to be part of our culture. Now, there's a conceptual framework that is proposed by Melnick et al. Since 2003. And here it has the same three legs, the same tenets that we talked about. The research, the best research evidence, the clinical expertise, patients' preferences and values, and the integration of these going towards a clinical decision. But all of this is done within the context of caring, right? So when we are providing the care, integrating all these three areas, coming to that final clinical decision, and then end up with the outcome being a high quality patient care. So that's the framework within which evidence-based practice operates, right? Further, evidence-based practice has steps. For you to carry out any project with using the evidence-based practice approach, there are steps that we need to follow. Some persons may describe a 5-step, a 6-step. Here, Melnick et al. Describe a 7-step because they added that first step 0, where nurses and other clinicians should cultivate a spirit of inquiry. When Cheryl was introducing this session, she talked about questioning. She talked about why do we do things the way we do? And so this is very important, not just among our professionals, but even our students. We should encourage them to question in the clinical area and even in the educational setting. Why are things done this way? And then following that question, it leads into framing that question. How do we frame that question? And there's a particular way using the Pico, and I will talk a little bit more about the Pico, but using that Pico question to frame that query that we had, that should be used in step 2 to search for the most relevant and best evidence to answer the question that we had. That now, when we have found that, that leads to step 3, where the studies that we found, they are critically appraised. What are they appraised for? The validity, the reliability, and the applicability, right? How best does it answer the question that we posed? Then, having found that, and there are tools to help us to do this. Now, in step 4, there's the integration of this evidence, the clinician's expertise, and the patient's preferences. And after doing that, now coming up with that decision, what is it we're going to do? What is it we're going to implement? It is evaluated within the clinical setting to determine if it really works. Then, if it does, we can now disseminate. And you will hear more about the dissemination when we're talking about best practice guidelines. Because I think best practice guidelines is that stage where the dissemination of evidence-based practice projects are working. So I told you I'd tell you a little bit more about that Pico question. What is the purpose of that? It is to identify the term that we will use in the search for the best evidence to answer that burning clinical question that we have. It ensures, that is, if it is written correctly, that the relevant studies are found that will help us to answer the clinical question. So the P is the population, you know, who is it we are studying? Is it patients with diabetes or patients with heart disease? What is the intervention? You know, are we trying to see that for patients with diabetes, their foot care, if we check the feet every day, so that would be the intervention compared to, or maybe say wearing the different types of shoes. Suppose we want to say, all right, we're going to wear shoes type A, which is leather, made of leather and so on. The comparison is using open-toed shoes, which is better in providing the outcome, which would be any prevention of cuts and sores and so on for the patient. And sometimes, but not all the time, there's a time frame to the question, right? So that's what it is all about. That question should not be too wordy. It should include the keywords that really matter to make sure that you find the right research articles, and it should be written in the past tense and should not be directional because it should not provide any bias at all. And Cindy at the end is going to talk about, going to give us an example of exactly how they went through this process. And so, cultivating an evidence-based culture, walking the talk, having it as part of our DNA, these are some critical components that must be there. So in terms of our philosophy or a mission statement, it should show a commitment to evidence-based practice, right, in our institution. That spirit of inquiry should be reviewing and analyzing our own practice and, you know, encourage students to ask questions. Don't prevent them from asking questions. When they ask questions, encourage it. And with evidence-based practice mentors, or sometimes we may call them champions, you know, who are persons who are trained, very knowledgeable and skillful in evidence-based practice procedures and so on. They are there to mentor others, to help our students, and to help to overcome barriers and so on in our organization. Really help to strengthen the and assist in making the change in evidence-based practice in our organization. There's a role for our leaders and our managers, and they should also be, I would want to say, evidence-based practice mentors as well. These are persons who really value and model evidence-based practice, right? And once they do this, of course, they will ensure that the resources are provided for our infrastructure, ensure that we have computers, the internet, we have access to the library, or have a librarian on site. You know, we have enough funds for training and things like that, right? And of course, recognition, which is something that we have begun to do, to recognize our staff members and the work that they're doing. So this is very important in ensuring a culture of evidence-based practice. And as you will see, evidence-based practice means change, right? It's all about change. And then we have to see that the change is necessary and go about applying the methods and strategies for change. Now, there are models used for implementation. And when I was looking at this, I realized that nurses were the ones who used modeling. They have developed these models that can be used to ensure that implementation of evidence-based practice occur. So as nurses, we believe in evidence-based practice, right? The models, there are 8 of them that I have here. They're divided into 2 types. The organizational related models, meaning that when implementing these, they're focused on implementing evidence-based practice in the organization-wide setting, while for the others, the Iowa, the Johns Hopkins, ACE, Stetler, Ottawa, Knowledge to Action, they're really for projects, you know, and individual nurses can use them and so on, okay? And I will talk a little bit about the ARC model, which is Advanced Research and Clinical Practice through Close Collaboration, developed by Melnick et al. And here it is. Here we have the assessment. We start out with assessing the organization and ensuring that they are ready. There's a culture for evidence-based practice. And they have a number of scales developed that can be used. And the next step would then be to use the information to identify the strengths and the barriers for evidence-based practice, you know, whether some of the things I spoke about before, the philosophy, the presence of evidence-based practice mentors, so the training and the management support that should be there or lack thereof. And using this information now, you would go on to step 3, where you develop mentors, they're training, and these persons are really experts in evidence-based practice, right? And so it is all about now they would be ready when you have a set of evidence-based practice mentors or champions, they're ready now for the implementation of evidence-based practice, because you're going to have several projects, they would be leading those projects, you'd be, and so on. And here we talk about the clinicians' belief about the value of evidence-based practice. And we are realizing that even when clinicians believe, they have strong beliefs about evidence-based practice and their ability to implement evidence-based practice, this is usually, it's also impacting the outcome. It's impacting the implementation itself and directly on the outcomes. And look at the outcomes that we have here. Main in the middle here is a decreased hospital costs, right? We're going to have increased patient outcomes, or rather improved patient outcomes. And then nurse satisfaction, nurse interprofessional cohesion, and reduced turnover rate, and so on, right? And so that's the outcome that results from implementing evidence-based practice, right? And so, as I said, the best practice guidelines are really, I'm not going to go into it because other persons are going to be talking about it, but they are really, you could see them as one aspect of evidence-based practice where they have now developed, they've gone through all the process and developed this guideline where they are disseminating, and that would be the last step of the evidence-based practice steps, right? And so that is evidence-based practice coming to life when persons develop evidence-based practice guidelines or best practice guidelines or clinical practice guidelines, and so on. Thank you so much. Thank you.
Thank you so much, Madam Pauline, for that wonderful presentation. I think you went over the 15 minutes, but since you're giving it us in a summarized breakdown, we accept it because it's a hard task to summarize it and give it to us like that. So thank you so much. And so I will ask Karen to go ahead and introduce our next speaker who will be talking to us about the best practice guidelines and utilizing them in nursing education. Okay, so we have coming to us now Miss Kimari Brown, who is a registered nurse and nurse educator. She enjoys the ease and efficiency technology has the potential to bring healthcare, which makes her informatics teaching assignment at USON a perfect fit. She led USON Mono to successful designation as Best Practice Spotlight Organization. This designation was given by the Registered Nurses Association of Ontario and is a marker of the school's commitment to evidence-based practice. We will hear her share her experience now.
Good afternoon, OKers. Thank you for that introduction, Karen. All right, so while I find my slides, I just want to give a disclaimer. Mrs. Anderson Johnson and I did not collaborate when making our presentations. So you will hear several instances of overlapping. I just want to put it out there. There was no collaboration. All right, so this afternoon, I'll be discussing with you how to utilize best practice guidelines in nursing education. I will do my best to stay within the 15 minutes time limit. All right, so this afternoon, we're going to be answering 3 questions. What are clinical practice guidelines? Why are clinical practice guidelines important? And how can nurse educators use clinical practice guidelines? So, first question of the evening, what are clinical practice guidelines? These are systematically developed statements to assist practitioners and clients to make decisions about appropriate healthcare decisions for specific clinical circumstances. And what that means is that clinical practice guidelines, they are an example of a filtered source of evidence. By this, I mean that guideline developers sift through or filter through all the available evidence on a topic the guideline addresses, then they filter out the sources that are of lower quality and keep the sources that are of a higher quality. The guideline developers then summarize the knowledge and give specific recommendations based on this information. If you hear me refer to a clinical practice guideline as a best practice guideline, don't worry, they're the same thing, no need for confusion. The US School of Nursing partnered with the Registered Nurses Association of Ontario, to use selected BPGs, which were developed by the RNAO, as we engage our students in teaching and learning activities. So think of the term BPG as the brand name of a clinical practice guideline. In the same way, we know that Panadol is the brand name for acetaminophen. All right, so we're moving with good pace. We're on to the second question of the afternoon. Why are clinical practice guidelines important? So contemporary nursing practice requires the use of high quality evidence to support nurses' patient care decisions. As clinicians and researchers, we have seen demonstrable proof that evidence-based practice is effective in improving the safety, effectiveness of nursing care while improving patients' health outcomes. Now, Mrs. Anderson Johnson would have gone through some of those benefits in her presentation. Despite the many benefits, patients, healthcare providers, and health systems derive from care that is evidence-based, the uptake of evidence-based practice is lagging globally. There is need for a meticulous approach for the integration of evidence-based practice in nursing curricula. As the gatekeepers to the profession, nurse educators are charged with the responsibility for ensuring that future nurses are equipped with the knowledge, skills, and confidence to engage in evidence-based practice. The WHO emphasized that nurse educators should demonstrate the skills and ability to design, implement, monitor, and manage curricula based on evidence. As clinicians, we know that it is not wise to make a decision about patient care based on the findings of a single study. We also know that the body of healthcare knowledge is vast and ever expanding, which makes keeping up impossible. As educators, we want to ensure that we are modeling the knowledge-seeking behaviors we want our students to demonstrate. So we obsess over ensuring that we read 1 million journal articles so that we can cite all of them at the end of a single bullet point on a slide. Is this you right now? That is exactly how I felt when I prepared that previous point about the need for nurse educators to be up to date on all the evidence, which requires a lot of reading. In fact, the vast body of knowledge, while good, can be a deterrent to evidence-based practice. Because why would you do all that reading to make a single decision or a single point when you can do what you've always done, or you can teach what you've always taught? Because of this, well-developed clinical practice guidelines are the perfect go-to source for practice recommendations. Now, bear with me. I run the risk of oversimplifying this, but I've done it and it really is as simple as it sounds. Because of what they are, well-developed clinical practice guidelines are the perfect go-to source for practice recommendations. They are perfect because they are filtered sources. Translation: the developers did all the location, evaluation, and synthesizing of information for you. Let me just go through that again. The developers of the clinical practice guidelines of the BPGs, they have already located the articles. They have already sifted through the good sources, the not so good sources. They have already evaluated and synthesized for you. They've done the heavy lifting. Clinical practice guidelines are also a very good source of evidence-based information because the recommendations are actionable. Translation: you don't have that issue of that dreaded study limitation of non-generalizability because the knowledge generated from diverse populations, settings, and disciplines are used to develop the recommendations. So oftentimes, I know we're familiar with reading a single research article, and when you get down to the bottom, it says, oh, the findings of this study are not generalizable because A, B, and C. With clinical practice guidelines, because the evidence is sourced from several disciplines, so not only nursing generated knowledge, not only knowledge generated from physicians, there's a diverse pool of evidence that is filtered through in order to develop these recommendations. And because of that, these recommendations are generalizable. And the last reason why I think clinical practice guidelines are so useful is because they are easy to read. Clinical practice guidelines are a tool to bridge the gap between when knowledge is generated and when that knowledge is used to influence patient care. Now, I'm sure you've all heard about that 18 to 21 year gap between when a study is done and when that information is used to influence patient care. Now, if you think about it, between that study and the 18 to 20 years it takes for it to influence patient care, the status would have changed. New knowledge would have been developed, which quite possibly would have rendered that first study irrelevant. Clinical practice guidelines, for this reason, it has to be easy to read. It has to be a lighter read. So compare the reading of a clinical practice guideline to that of reading the results of a randomized control trial. Reading the results of a randomized control trial is heavy lifting. BPGs, not so much. Clearly, I could go on and on and on about why clinical practice guidelines are important, but I must restrain myself and move on. So we're now going into the meat of the matter, what you are here for, to hear from me about this afternoon. How can nurse educators use clinical practice guidelines? So the first thing is to create a culture of evidence-based practice. Now, when I saw Mrs. Anderson Johnson speak about this, I was just smiling from ear to ear because it is so true. A fundamental way to create a culture of evidence-based practice is to incorporate it in the school's vision, mission, and values. Now, let's have a look. Let's have a look at the mission of the UWI School of Nursing. The mission of the UWI School of Nursing, UWISON, Mona, is to lead the Caribbean region in developing undergraduate and graduate programs, in delivering undergraduate and postgraduate evidence-based nursing education. There it is, right in the mission. And if you read the values, you will see it there as well. We often overlook these statements, but they are extremely important to creating that culture of evidence-based practice in the organization, because these statements will guide the biggest decisions down to the smallest decisions. For example, when the head of school is hiring, the head of school is looking for a nurse educator who has that similar focus, who places that similar importance on evidence-based practice. Because when we employ persons who share a similar vision centered around evidence-based practice, it will only encourage or help to create that culture of evidence-based practice that we want in our organization. All right, next, congruence is key. This means that when deciding to implement or to integrate or to use a clinical guideline within your course or within your school, you must select a guideline that is based on the needs of the institution. For this, it would be useful for the School of Nursing to conduct a gap analysis to determine which areas of the curriculum needs further bolstering. You could also conduct a review of the required readings for the courses in the program to determine if they continue to meet the need for teaching students based on the best available evidence. And these are some of the things that we had to do at UWISON before we embarked on our best practice spotlight organization journey. All right, so the next thing that we can do as nurse educators to use BPGs or clinical practice guidelines is to incorporate it in classroom discussions. Find a controversial recommendation and discuss its applicability to the local context. Now, I don't know about your students, but my students like controversy. They like those spicy things. So you find something that you know will generate a bit of controversy in discussions. So for me, what I do, I use the falls prevention guidelines from the RNU, which advises against the use of bed rails as a fall prevention strategy. I'm going to say that again because I know a lot of you here are from Jamaica and you're thinking, what? Did she say that correctly? Yes. One of the recommendations from the BPG that addresses fall prevention advises against the use of bed rails as a fall prevention strategy. Now, when our students go out there and they see bed rails being up ×4, as they like to write it, they're thinking, but miss, that must be wrong. So already they're reading something that is contrary to what they're seeing. So it generates that interest. Now, this type of discussion is useful for two main reasons. It allows them to be aware of what the evidence suggests, and it also gives them an opportunity to recognize that context is important. Mrs. Anderson Johnson would have made reference to that in her presentation, the importance of context in evidence-based practice. So another very important thing that you can do as educators is incorporate the BPGs and their recommendations in classroom discussions to show students that what they are seeing is evidence-based practice. Too often, students tend to focus on those things that they are not seeing or those things that are not evidence-based practice, but it's very important to expose them to those recommendations that they can see in practice. You also want to make the clinical practice guidelines visible to the students. What I mean by that is put it on their course outline as a required reading. This generation is often described as the microwave generation. So you might put it on the course outline, but that requires them to go and do a Google search. I mean, who wants to do a Google search these days anyways? So you take it a step further. You place the link to the BPGs or whichever clinical guideline that you're using. You place that link in their virtual learning environment. Now, if your institution does not have a virtual learning environment, email the link to the students. Make it easy for them to access the information. And you also want to use it to support the development of your lecture support tools and class activities. So if you're creating slides, ensure that you are citing the BPGs if you have used them. Ensure that you're citing and placing the references in the slide so that when they get the slides, they see it. If they want to read further, they have the link right there. It is also applicable to the development of the rationales for your clinical skills. So if the student is interested in learning, okay, why do I need to tell the patient my name? You know how they say there's an app for that? There's a BPG for that. There's a clinical practice guideline for that that explains to the student the evidence behind explaining the procedure to the patient or introducing yourself to the patient. So by citing it in your tools, by citing it in your resources, it remains visible to the student. The final thing that I want to encourage you to do in your use of BPGs or any other clinical practice guideline is to be creative. There is hardly a wrong way to use the clinical practice guidelines or BPGs in teaching and learning activities. Be creative. Ask them to use it in role plays, ask them to debate a controversial point in groups, ask them to do a critique of a practice that they see in the clinical area. The sky is the limit. Be creative with your use of the clinical practice guideline. It is like any other source that you would use, only better because it is a filtered source. This brings me to the end of what I hope was a very concise and informative presentation. Mrs. Garrix-Lloyd, how did I do on time?
I will say thank you so much, Miss Brown. You did great.
Okay, awesome. Thank you so much for having me. Thank you for listening. Enjoy the rest of the evening.
All right, thank you so much, Mr. Brown. Colleagues, just before Mrs. Jones-Fraser introduces our next speaker, just a little bit of housekeeping that we need to keep repeating. I've already put it in the chat about 5 times. Persons are joining. I'm sincerely hoping you're here to get the information so we can impact patient delivery, but just in case, you also need to have hours. Hours can't be assigned to Acadia or a Leslie or a Nurse Brown or to a Galaxy iPhone and a something 10. We're asking persons to please ensure you've joined using your full names, Christian names and surnames. Thank you, as you'd want it on your certificate. I've also put the registration link in the chat. We are not collecting names and emails here. You would need to do that on the registration form so the certificate can be emailed to you. So please pass that on if you have other persons who will be joining as well. Thank you. So now that you've heard about the summary of evidence-based practice, and Ms. Brown has been so kind to tell us how can we use it in education, because we need to start there to ensure we're preparing our future colleagues to be able to carry out EBP and to use the guidelines.
We're gonna hear from Mrs. Jones-Fraser, from our next speaker, who's going to talk to us about using BPGs in the clinical setting and give us some results because they've been using BPGs. Over to you, Mrs. Jones-Fraser.
Thanks again. Now we want to welcome Mrs. Judy Ann Alexander, who is a graduate of the University Hospital of the West Indies School of Nursing. She has obtained postgraduate certification in critical care nursing, and she worked in that area for many years. She holds a Master of Science degree in Health Administration obtained from the University of Technology, Jamaica, which included an internship at the Johns Hopkins Hospital in Maryland. While there, she worked in the hospital's epidemiology and infection control department as a member of the Quality Task Force, which oversaw the seamless transition of patient care services to a newly built 1,000-bedded hospital. Mrs. Alexander is currently the Quality Improvement Officer at the University Hospital of the West Indies, UHWI, and has held that post for the past 5 years. She is the Best Practice Spotlight Organization Project Manager, for which the UHWI has earned its designation from the Registered Nurses Association of Ontario in 2019. Her expertise extends to professional certifications in industrial relations and principles and practice of project management. She serves on numerous committees at her place of work. One of the philosophies, her personal philosophy, is from Will Durant, which states, "We are what we repeatedly do. Excellence is not an art, but a habit." So we welcome her to speak about evidence-based practice in the clinical setting.
Thank you very much for that introduction, Mrs. Jones-Fraser. And I will do like Kimari and give a disclaimer that Mrs. Anderson Johnson, Kimari, and myself, we did not collaborate, but we're very good friends. And so we will continue to talk about evidence-based practice. And my presentation really is just to operationalize what Mrs. Anderson Johnson and Kimari has just said before. All right, are you all seeing my screen? Okay, so a few objectives. I'm going to provide a context, or the context for which I'm going to be discussing evidence-based practice and BPG implementation. So I'm going to give you an overview of the university hospital. I'm going to reiterate what evidence-based practice is. I'm going to share with you some of the reason for our BPG selection, and I'm going to discuss benefits or goals to the implementation. Of course, with everything, there are challenges, and I'd like to share that with you. But with our challenges, we have accomplishments, and that will be shared as well. And then I will summarize. So the University Hospital is the first and one of the largest teaching hospitals in the Caribbean. It is one of 3 Type A hospitals in Jamaica with a bed capacity of 579, and this includes 21 intensive care and high dependency beds. We have 6 neonatal intensive care unit beds and 7 operating theaters. We offer the major services: medical, surgical, emergency, intensive care, ambulatory, outpatient clinic services, as well as specialist services. We also have a private wing, the Tony Twaits wing, which was established in 1990. Our main academic partner is the University of the West Indies Faculty of Medical Science, and UWISON is a part of that faculty. The hospital also expanded to include the University Hospital School of Midwifery, and we have other paramedical disciplines. We're committed to teaching, research, and the provision of high quality care for the region. And this is achieved by developing, implementing, and maintaining proactive and responsive policies, strategies, systems, and practices. And this is what has led us to the implementation of best practice guidelines. So at University Hospital, and this is also context, and you will see the vision and the mission that Ms. Brown spoke about before, the use of evidence and teaching coming out in our vision, which is to become a dynamic, environmentally safe, adequately equipped organization with trained and highly motivated staff dedicated to promoting teaching, research, and the delivery of the highest quality healthcare to meet the needs of the region. As such, making a positive impact on patient care through evidence-based practice is one key link for the bridge to this gold standard of care that we want to achieve. So what is evidence-based practice? And you would have seen the stool, the pronged stool that Mrs. Anderson-Johnson spoke about. So just to reiterate that evidence-based practice really relies on the use of the best research evidence coupled with expert skill and knowledge in the right context, taking into account the patient's or the client's needs and preferences. At University Hospital, the aim of the evidence-based practice is really to transform nursing through knowledge with successful implementation and sustainability of clinical practice guidelines or best practice guidelines. And so what are some of the reasons for selecting a few of the guidelines that we have implemented? And I'm going to just discuss 4 of them in this presentation. So really and truly, the best practice guidelines were selected and implemented because of some concerns we had in the quality standards and the patient outcomes at the University Hospital. And they were in categories, and I'm gonna say patient falls. We were very concerned about the rate of patient falls that we had, pressure injuries, the context of a person and family-centered approach to care delivery, and professionalism in nursing. And I'm going to go into this in a little bit more details so that the topics that Mrs. Anderson-Johnson spoke about in the selection and the use will come out. And so the prevention of falls, I'm gonna do them one at a time. So I'm gonna talk about falls. The prevention of falls and falls-related injury is a goal of the University Hospital. The ability to maintain patient safety, including the prevention of falls, is vital, and staff should possess the requisite skill to do so. Patient fall, especially in the adult population, 60 years and older, has been a challenge for us at the University Hospital. Data collected from incident reports highlighted an increase in the number of patient falls occurring between 2009 and 2014. For the period 2009 to 2011, there were 247 reported incidents of patient falls. And so we were averaging something like 82 a year. And yes, this is a lot, and you may be saying, oh, but guess what? It progressively got worse. In 2012, we went up to 137. In 2013, we went up to 155. And by 2014, we were at 216 patient falls. And the falls were reportedly among the elderly patients. And Ming et al., Dr. Ming and company did a study that revealed that 44% of the patient falls recorded in a 3-month period were in the elderly population. The study also identified several modifiable risk factors for falls, and we recognize that these factors could be addressed by the inclusion of evidence-based nursing action. So the study resulted in an emphasis on fall prevention as a priority clinical strategy. And therefore, we decided that we would implement the best practice guideline prevention of falls and fall injury in the older adult. The ability to assess and manage pressure injuries is really critical in maintaining patient safety. A review of the data documented on pressure injuries for the period January 2011 to December 2014 revealed a record, a whopping 407 patients with pressure injuries. The information we retrieved were from the medical ward, surgical areas, we had the gynecology ward, and of course the intensive care unit. But upon looking at or examining the data, it was discovered that a detailed and descriptive reporting really was absent from this documentation. And the areas that we found lacking were related to the inspection of the patient's skin and the documentation of the findings upon admission of the patient. We saw absence of a risk assessment. There was absence of staging of the pressure injuries, and there was little to no documentation of the preventive measures or of a management paradigm with regards to pressure injury management. In addition to that, we recognize that the policy on the prevention and management of pressure injury was outdated. So there was an obvious gap in this critical quality of care indicator. And we recognize that equipping the staff and the interprofessional team with the requisite competencies in assessing and managing pressure injuries at various stages of development based on the most current evidence would be helpful. And so we implemented the assessment and management of pressure injuries for the interprofessional team guideline. So putting the patient and their family at the center of every decision and empowering them to be equal partners in their care is a goal that we would like to achieve at University Hospital. So although based on our mission and our vision, a holistic approach to care is encouraged, it is not consistently transferred to practice. As before, we had no formal structure or guidelines in place to ensure that patients and their families were at the center of decisions for their care. As such, the concept of patient and family-centered care presented or represented a paradigm shift for us at University Hospital, as it really was customary for the physicians and the organization to set the goals of care for the patient with little or no input from the client or from their relatives. So through the implementation of the person and family-centered care guideline, we were able to bring the new era of patient and family engagement. And we were also able to shift the conversation from what is the matter to what matters to you. And of course, we cannot forget professionalism in nursing. Nursing is our profession. And the professionalism in nursing really is necessary to achieve a healthy workplace environment and to enhance patient outcomes and also for nurses' morale, satisfaction, and for the organization as a whole. So of course, there were concerns regarding nurses' lack of professionalism at university hospital. And you would have read some of the newspaper articles, that suggested that persons were less than satisfied with the level of professionalism. And so we also received a high level of complaints, right? The senior director who is on will tell you that, the complaints come in. And so we had to do something about it. This really and truly prompted our selection of the professionalism in nursing guideline. Additionally, we have implemented other guidelines, and we have even updated guidelines based on new evidence. So we have moved from preventing fall and fall injuries in the older adult to really preventing falls and reducing injury from falls. And we have also implemented another guideline promoting safety alternative approaches to the use of restraints, as well as we have incorporated recommendations in student, staff, patient, and family teaching. And these are some examples of the guidelines that we have implemented. So what are some of the benefits? Some of the goals that we thought and that we have experienced benefits from. There's reduced variation in care, right? So for the areas that we have implemented guidelines, you will realize that those areas are doing the same standardized processes. We have transferred research evidence into practice. So we have moved it out of the books and off the internet, and we have now converted it into actionable items, 1, 2, 3 steps that you can do. It has helped with clinical decision making because you have the background and the evidence to support the actions that you have taken. We have stopped interventions that have little effect or cause harm. And one of the big points or sellers that we have experienced is a reduction in cost. And I will go about, when we talk about our achievements, I'll go into a little bit more detail about that. And so what are some of the challenges that we experience during the implementation of the guidelines? Maintaining momentum and keeping the staff motivated. Staff members tend to be distracted or they move on to things, and keeping them interested and engaged is challenging. Their interest wane, they think, oh yes, we have achieved this designation, and yes, we have accomplished, and so they have moved on. So we have to keep them constantly engaged and motivated to continue the process and embed the changes in our practice model. Maintaining the practice change is a challenge, because I don't know for those persons who are on this platform, but you have to be behind nurses to do simple documentation, right? We have this in our context, in our culture. There is a challenge in getting the nurses, to document what it is that they have done. So when we have implemented the risk assessment tool, they do it for the first 3 weeks or for the first month. And then by the time you finish auditing the entire hospital and go back to page 1, you have to start the process all over again, because they are not consistent with the use. Data collection is a challenge for us. We are still using paper-based medical records in some areas. And so we have the challenge of missing medical records, missing dockets and missing notes. Resources are big challenge, and not only financial resources or equipment and devices, but human resources as well. The increase in attrition rate has really affected us. It has affected our staffing. It has affected our ability to continue with the implementation in that. The turnover has caused us to be very repetitive in a lot of the processes that we have to do. We have to be constantly re-engaging persons, because they would have left with that knowledge and that champion would have gone. And so we have to constantly be doing replacement. And of course, the roller coaster of change, you know, the ebbs and the flows, the ups and the downs, the peaks and the low is very challenging as well. And like I had said, with challenges comes rewards. And so some of our accomplishments are as follows. We have been able to establish a standardized care delivery system supported by policies, SOPs, and guidelines to govern the practice at the university hospital. We have been able to discontinue some of the ineffective practices that we had. There has been a reduction in patient length of stay in some areas. We have reduced litigation, which affects our cost. And this is with regards to some of the pressure injury associated litigation that we used to get. There has been a reduction in those, and we have improved and is still improving our public image. We have had significant reduction in not only the rate, but the injuries associated with patient fall. Last year, hospital-wide, we had a 47% reduction in the number of patient falls. But in terms of units, right, or programs, we have seen also significant reduction. For example, in the mental health program, we had a 71% reduction in the number of patient falls experienced in that program, as well as in the child health program, it was 44%. And so we have been seeing, we have been getting real good outcomes with the implementation of the prevention of falls guidelines. We have achieved and really is maintaining our international accreditation from the best practice, from the Registered Nurses Association of Ontario in the form of a best practice spotlight organization designation. We are now recognized as a leader in clinical excellence. It has enhanced our professional practice and team collaboration. Team members, some of whom are on this very platform here from the clinical area, are asked to be on several committees and boards talking about evidence-based practice and really just sharing their clinical expertise. We have been able to sustain the use of evidence-based practice through staff education. I spoke about the policies and SOPs that we have implemented. We have quality improvement activities that embed these evidence-based practice changes. We have integration of best practice into our documentation systems to improve the documentation. And also we have ensured that our new hires or new staff are orientated to the use of best practice guidelines and the evidence-based practice culture that we want to maintain here at University Hospital. We have also provided a venue or an avenue for the evaluation and research projects related to knowledge uptake, policy implementation, clinical, educational, and financial and system outcomes. And we partner with the University of the West Indies School of Nursing. Their undergrad and postgraduate students are facilitated with regards to conducting research and collecting data here at the University Hospital as well. So basically, in summary, we believe that in order to affect better patient outcomes, new knowledge must be transformed into clinically useful forms, and it must be effectively implemented across the entire care system within the context of that system. And it must be measured in terms of meaningful impact on performance and on outcomes. And this is just an image. It's a very old image, so some persons are going to be very upset with me on this platform. But every implementation requires a team of persons to help with that. And so this is just a subset of the team that we have worked with. And I just want to thank you for having me share with you.
Thank you so much, Mrs. Alexander. And we thank you again for giving us a little bit of your time on this, your very special day. So we have heard about EBP. We've talked about in nursing education as we prepare our future colleagues. We've heard about the guidelines that were implemented at University Hospital and the numbers in the reduction of falls, 71%, 41%, sounding good. And now we are just gonna ask Mrs. Jones-Fraser again to introduce to us Professor Beckett, who will be talking to us about how we're gonna develop that inquiring mind and how we're gonna be able to look at an example of how a guideline was utilized and getting to evidence-based practice use.
Yes, so Dr. Cindy Beckett is the Assistant Director of the Academic Core and the Director of Evidence-Based Practice Certificate Program in the Helene Fuld Health Trust National Institute for Evidence-Based Practice in Nursing and Healthcare, and an Assistant Professor of Clinical Practice at the Ohio State University College of Nursing Teaching, EBP, at the master's and doctoral levels. She's working to integrate EBP into academic curriculum across all levels, that is from the RN right up to the DNP, and is directing efforts at the Fuld, I'm hoping I'm pronouncing that correctly, to implement and oversee an interprofessional value-based certificate in evidence-based practice. Dr. Beckett has been a nurse for 41 years in various leadership, academic, and research roles. Her research focus has involved perinatal, pediatrics, and family, rural and underserved communities and populations using qualitative, quantitative, and evidence-based practice methodologies. Dr. Beckett has been mentoring, teaching, and leading evidence-based practice in the clinical and academic setting for over 15 years. We look forward to her presentation now.
Thank you so much. I'm so excited to be here, and I thank you for the opportunity to share just an experience that we had from the Fuld. So I know I only have a very short limited time, so I'm going to share our experience. So our learning objectives are to really give you an idea of a strategy on how you can use evidence-based practice to make a practice change very quickly to impact a clinical setting. So I hope that you'll identify at least one strategy on how to provide that evidence-based practice during a pandemic and identify some recommendations for proning patients, which is our population. So the Fuld Institute was contacted by multiple providers from across the United States about issues about COVID. When COVID hit last year, we didn't know what to do. We had so many patients, and I'm sure in Jamaica it was the same way. Many of our practice issues came under question, and it was, what is best practice? How can we adapt to this huge number of growing patients, increase complexities, increase acuities? So we were able to pull together a team. We identified, all of us came together. We looked at the different issues that we were being brought forward. We began to look at the early data, and we divided into teams to try to turn around a rapid response to this issue, of what can we do in the clinical practice. We followed the steps, and we've had these beautifully discussed tonight by Pauline and others in terms of the evidence-based practice process. But we literally followed each of these steps in our journey. We were assigned, my group, to early proning in COVID patients. This is a great representation that came out of the Health Ministry's advisory for self-proning. But we had a team of 6 that was pulled together. Myself and Dr. Cindy Zelafro led the team. We had additional members that were DNP students, DNPs, and it was really great having a team because we literally were assigned this at the end of February, and we were presenting a webinar on it in mid-March. So this was a rapid turnaround process to get the evidence out for clinical practice. I looked up these numbers today because the numbers we had were a little dated, but worldwide, we have almost 2 million cases of COVID. With the Delta variant, that number is increasing every day, with over 4 million deaths. The US has reported over 35 million cases with approaching 630,000 deaths. Jamaica, from the website, had 52,504 cases with 1,182 deaths. Every death is too many. So our goal was, what can we do to try to address this issue? Our clinical inquiry was why. We created a Pico question. We did an extensive search of the literature, and we looked for background information such as this, kind of the pathophysiology of COVID, the symptomology of COVID, and began to look at some of the issues that were out in the evidence. And much of this information was readily available by the media, but we wanted to know what is out there in terms of COVID. And initially, there was very little that was presented. We also looked at the ARDS literature because they were looking at management of patients with COVID very similarly to working with ARDS patients and the classification of ARDS patients. We looked at literature that looked at proning, not for proning of patients who were already intubated. There was a plethora of articles out there for patients in critical care and the benefits of proning intubated patients. But what we were looking at is what can we do to help these patients before they need to be intubated, and maybe to prevent intubation. So there were beginning to be articles published very quickly about proning and its effects of COVID. And we've known that proning can be a positive thing for respiration. We prone babies, when they were little. We self-prone. Many people will lie on their stomachs because it's much more comfortable. And so a very simple, cost-effective approach could be proning. So we began to look at the physiology. So we looked at background literature, we looked at physiology literature, and we looked at what research was out there for early proning. And if you noticed in the diagram, and I'm sorry, the Zoom is not as clear, but you get a physiologic benefit when you're laying on your abdomen as opposed to your back. The lungs are able to drain more efficiently, and you're able to get better ventilation. So it makes sense if I've got COVID and it can cause all kinds of issues in my lungs, increased fluid, increased scarring. If I can lay on my abdomen, I'm going to be able to breathe better. In China, they started looking at patients that self-proned, and we're starting to see huge improvements very, very early. And this was a publication, Sohn et al. In 2020. This was one that we looked at very, very closely because the strategies that they were looking at were very, very simple. They could be used in any type of hospital facility, whether it was a small rural hospital all the way up to a big urban center. The early interventions, they looked at screening, they looked at restricted fluids, and that awake proning. So that was just one example. So we did this massive search, looked at multiple databases. So we decided we were going to create a scoping review. So we did a comprehensive and exhaustive search of all of the databases. We even went into gray literature. We did title searches. We used multiple different search strategies. We ended up finding 98 articles, which we then appraised and determined that 7 of the articles really addressed proning, early proning with patients with acute respiratory disorders like COVID. And we had 13 additional articles that we kept for background information. This is just an example of our levels of evidence tables. So we did have one systematic review, and the Sun et al. Article was the only one that was specific to COVID. We had 3 cohort studies, a single descriptive study, and a couple of expert opinions. So the evidence was all over the place. Since then, there's been some additional articles published. This is our outcome synthesis table for early proning. And as you can see, all of the green arrows are positive. So whether it was an increase in perfusion, an increase in oxygenation, or a decrease in need for ventilation, early proning showed positive outcomes across all of the diagnostic measures. And I know I'm going quick, but I want to make sure I can get through and explain the whole process. Our indications for early proning, again, multiple articles, and the SON article really looked at those basic assessment criteria. So these were things we felt were really important for all of our providers. And I'll summarize this in just a minute. But so our early indications were if they had an increased respiratory rate, if they had a heart rate of greater than 120, if their oxygen sats were less than 93% at room air, if their FiO2 was greater than or equal to 0.6, looking at their other measures, the PaO2, FiO2, less than 300 would be equivalent to a mild ARDS, and then less than 200, a moderate ARDS. And if they had a velar collapse seen on X-ray, and primarily it was CT scans. So all of these indicators were, I have a patient that is at risk for having continued complications, continued journey toward that ventilator. So this is a patient that we want to start early proning right now. So I know you can't read this. This is all the literature and all of the complications related to proning. So when I first looked at this, it was like, and it's divided in colors by systems. When I first saw this, it was like, oh my goodness, what are we recommending? Is this something that's really important? But as we delved into it, we found out that there were some contraindications, but they were very valid. If I had a very large abdominal girth, so I was extremely obese, or maybe I was pregnant, proning would not be appropriate. If I had underlying cardiac issues, being in that prone position could exacerbate problems. If I had active bleeding, proning is not the priority, maintaining that, stopping that bleeding and stabilizing that patient. If I have neuro injuries, again, we saw a lot of patients that were coming in from traumas that were positive for COVID. You have to treat the patient first and stabilize those ABCs to make sure we've got airway, breathing, and circulation. So those trauma patients, you have to treat the trauma first and then determine when, if they're able to prone. Increased ocular pressure or ocular surgery, having them in a prone position puts increased pressure on the eyes. If you have drainage tubes, especially chest tubes, you can create leaks. Whoops, sorry about that, I was timing. You can have, tracheal surgery, asthma, high dependency of airways, increased weight, and increased height of greater than 6 feet 6 inches. So we created synthesis tables which looked at positioning, length of time, patient monitoring, resources needed, and potential complications. And what we came up with was the alternate swimmer's position, one arm up, one arm down, one arm up, one arm down, or arms alongside of the body, alternating head position to the left or the right. And they needed to prone for 2 to 5 hours as tolerated, and at least twice a day. If they wanted to prone longer, they had a bigger benefit. And we needed to monitor these patients with the same vital signs that we were doing before and really watching their oxygen sats. Resources that were needed, you might need, definitely protective equipment. You may need a footboard, pain meds, extra EKG leads because you're turning the patient. You may need extra staff to help, even if the patient's awake and alert, to turn them in a position. You may need suction, pillows, sheets, towels. You may need turning support. And if you have them, the resources, a Volman prone positioner, which will automatically turn the patient. So the literature recommended, that you really assess closely for pressure ulcers, facial and orbital or ocular edema, accidental dislodgement of tubes, aspiration, eye injuries, nerve damage from positioning, wound dehiscence if they've had a surgical site, cardiovascular instability, and hemodynamic instability. So key points to leave you with. Oxygenation has been the biggest issue to manage for our COVID patients. research supports early proning, and it's a natural way for the lungs to evacuate additional fluids and to increase oxygenation. The literature clearly supports an easily implemented, cost-effective intervention that shows improving outcomes. Early proning does require additional staff, patient and family education about encouraging them to lay on their abdomen as much as possible. And patients who are early prone, they need to be monitored so they don't develop conditions, complications. But we definitely need to do more research in this area. So we are recommending, based on the evidence, that we implement early proning with any patient that has been diagnosed with COVID. If they're still at home, that's even better. Encourage them to lay on their abdomen. But you need to train your staff and the patients about why this is important. Make sure you have the resources that are needed. Twice a day is, as tolerated, and a minimum of 30 minutes, but average of 2 to 5 hours. Continuing monitoring for respiratory status, watch for any potential complications, and document the detailed proning and monitoring information. Engage your quality improvement to support tracking and trending of the data, and engage your researchers to conduct research on early proning. So we have some references, and just to pull it all together, we had a challenge that this was a clinical issue that we needed some questions with. We had a spirit of inquiry. We created our Pico, we did our search, we appraised the evidence, we synthesized the evidence, we made recommendations, and our clinical partners in the communities across the United States have instituted proning and have found amazing outcomes. So thank you so much for my short couple of minutes there, and I'll stop sharing. There we go.
Thank you so much, Prof. Beckett. That was awesome. Cindy, it's a good way to show how it is that we are able to recognize that there could be a challenge or something could work. It is a lot of work, because when we looked at your chart with all the literature, I'm like, I agree with you. It looks confusing.
It definitely
but it's a great way.
Yes. But it's a great way to work. So if you have a challenge, don't do it by yourself. Grab a team, pull together, and it's amazing what you can get done. But let me know at the end if you have questions.
All right, thank you. So it really goes to show that, and this is very relevant to COVID as it is. And as you said, if persons are at home, even greater. So the recommendations were awesome. Maybe it's something we need to consider here. Thank you very much, Prof. Beckett. So we're asking persons again, just make a note of your questions because we're almost finished. And we want to ensure that if you have something to ask, you type it in the chat if you can't keep it. But we're going to have a question and answer session. So coming up next, we had a colleague from an institution here in Kingston who saw a previous presentation, had an interest in best practice guidelines and wanted to just share for a few minutes with us on what she thought of it, how she felt about the workshop, and why it's important moving forward. So again, I'll ask Mrs. Jones-Fraser to go ahead and do the introduction.
Right. So we have Mrs. Sophia Reed Matthews. She has been a registered nurse for the last 22 years. She has worked in mental health for all of those years. She's currently a departmental nurse manager at the Bellevue Hospital. She lives by the phrase, "A wise man learns from the mistake of others, a fool from his own."
Thank you so much, Mrs. Jones-Fraser. So no, for the persons who know me, I am not Mrs. Reed Matthews. She is our colleague and she's actually on duty and wished to join us. But as it turns out, as those of us would know, there has been an emergency. And so she had sent her slides. It's just 4. And aptly you can see she named it. I'm excited. How about you? And so she just had 3 quick points that she wanted to share with us. She developed her interest in the best practice guidelines through a previous presentation that she had attended. And what she really loved about the best practice guidelines was that they could be nurse-led initiatives. Ultimately, she thought it would be great because she wanted to be able to impact and improve patient care delivery. And so she would have reviewed the best practice guidelines, and she looked and saw at least 3 that could have been implemented in her institution at the Bellevue Hospital. She also wanted to motivate and include her colleagues. And as I think Juliani was represented, spoke about the guideline of professionalism, she also wanted to improve the image of the profession itself and the institution. And then her second point was that she completed the best practice champion training in June of this year. And so she wanted to share with us that the training is currently being offered, through the Registered Nurses Association of Ontario, and it's free. She went ahead and shared that information with the nurses at her institution. And she also went ahead and spoke to a few colleagues who she thought could have been a core group to do the training and look at implementing the guidelines that were identified. Her main takeaways from the training, it's a 2-part training, and she recognized that based on what she found and heard, that we were not practicing a lot of the BPGs here, that it really can be a great motivation for the nurses to participate and to lead these initiatives. And she was most impressed with the possible impact it has on patient care delivery. And again, I will refer to the statistics that Julian would have presented on the guidelines they've implemented. And her last point would be on moving forward. Her thoughts are that it would be great to have additional educational and clinical sites become best practice spotlight organizations, but it would be even better to have institutions that are facilitating the implementation of best practice guidelines. She wants them to also look at having the staff being able to complete the champion training. And she is saying that there is still one training available for this year, and she's reminding us that we don't need to pay more than anything else. Perhaps what the staff would need would be the time to be able to complete it. So her presentation would have taken us into the next item on the agenda, which would have been to talk a little bit about the training and the best practice guidelines to share with you. So we want to thank Mrs. Reed Matthews, though she wasn't able to join us, that she would have sent her thoughts and shared her excitement. I will tell you personally that I had shared the training sessions information with her, and she clicked on it. And after she did the first day, she messaged me and she said, my brain feels alive and kicking. There are so many thoughts going on that I think we could go ahead and implement. And so I'm going to be sharing with you at this point. This is the site of the RNAO, and this is where we can find out about the best practice guidelines. So I'm going to put this link in the chat on YouTube as well. And so when you go to this page, you will see here on the right hand, it says Best Practice Champions Training, Virtual Workshop Session 1 and Session 2. So based on what you're seeing on screen, Session 1 is August 10, and it's 3 hours for each session. We just need to verify because they have 9 to 12. It may be that it's 8 to 11 for us, depending on the time zone. And then it's important, you will only become a best practice guideline champion after you've done both sessions. So session 2 is going to be on August 17, and it's also 9 to 12. And so if you click on that, let me click it for you. It gives you some information about registering, the time, and it explains to you about the network and the team and the champions workshop and why it's important for us to participate, what you'll achieve. And when you've registered, they have a toolkit for the implementation of the guideline. The RNAO is awesome. These guidelines come with the full work of how you could implement it, what you can do, how are the suggestions that would work, and also guidance to implement what it is. So it tells you what's going to be covered in the sessions, and you would need to ensure you're registered for both sessions. Now, I also wanted to just quickly share, what if you want to have a look to see what guidelines you think you could implement? Because the championship training is just for you to become a best practice champion, and then you need to have some guidelines to implement. So you'll see I've clicked the best practice guideline link here. And so they have a complete listing of their best practice guidelines, initiatives, and they will give you everything. If you say search all, they will show you all of what they have. So just a quick look, they have some here that you could see, and it's important that we look at it. They have guidelines for mental health, for critical care, for pediatrics, for anything you can think of, and for our colleagues in the clinical area, in the educational sector, it's the same principle. They're able to help us, and we are able to utilize the guidelines as teaching resources and to ensure that we are preparing our future colleagues for being best practice guideline champions. So I'm going to put the link in the chat. You're able to click it, and you're able to go ahead and look at what guidelines you could consider implementing or starting a conversation in your institution, in your health center, in your region. And then you could also consider participating in the workshops that are upcoming for August 10 and August 17. So I'm hoping, having stayed with us, you've been listening closely, and you're recognizing that we can be a voice to lead and be a very integral part of the future healthcare that we're envisioning as nurses, that we can put ourselves at the forefront and lead some of these initiatives to impact the patient care delivery and to ensure that we are using the best evidence and the guidelines, and we are looking at impacting on what we're offering. Because certainly we would also want to ensure that if and when, we hope it won't, but it may, that even ourselves, we found ourselves not well, we are sure that we would have been a part of implementing something that would have impacted on our recovery. And so I have a few questions to ask of the persons, and I will put those in the chat because there's going to be a prize for the person who can answer all the questions. But before we get to that point, this is the section where I'm going to be asking us to pose our questions to our presenters. We have Mrs. Anderson Johnson, who gave us an overview of evidence-based practice. We have Ms. Kimara Brown, who spoke about using the best practice guidelines in the academic setting. Mrs. Julian Alexander, who spoke to us about in the clinical setting. Professor Beckett, who gave us an example of what it is to have that inquiring mind and look at how we could utilize evidence-based practice. We had, in absentia, Ms. Reed Matthews, who shared with us what it was like for her in completing the training and why she thought it was necessary. So this is the section where we're going to allow you to type your questions in the chat and or to raise your hands and be acknowledged so that we can have a little bit of discussion and on how you will utilize and or apply some of this when our session is complete. So you may go right ahead. All right, so Elizabeth, I am hoping that you would have heard my response. Thank you. She's asking how can she get training as a best practice mentor or champion. And so I'm going to be putting the link shortly, and I will encourage you to go right ahead and register for the best practice training that's coming up on the 10th of August. All right. Is there anybody else who has another question for us? While you're thinking of your question and or typing it, I will double check if any of our viewers over on YouTube would have any as well. I'm reminding persons again, I have put the registration link in here several times. We are not taking email addresses and names here. Persons need to be registered. From the registration forms is where we will get the information to complete the certificates and to send them via email. So I noticed there are several persons who are here with us who are actually not registered. I'm asking persons to go to the chat, click on the registration link, and please ensure you've completed your registration for the session. Mrs. Anderson Johnson, I see your hand. Go right ahead.
Yes. Wow, this was so wonderful. Thank you all. And thanks, Cindy, for coming. And just to let you know that I will be working with Cindy in the coming years, months and years. Cindy, I had stepped away for a while, and I don't know if you also had talked about the food and some of the opportunities for evidence-based practice information and training that is there available.
Thank you, Pauline. We have with the Fold Institute, and I will put the website in the chat for you. We offer online programs. There's a short online overview that's offered with the semesters that's absolutely free. So it's a free, very basic evidence-based practice information. It's a modular program. We also offer a more advanced modular program that most people finish in 3 to 6 months, and that one has continuing education hours. We also have a more intense, more advanced program, which is our 5-day intensive EBP immersion, which is what Pauline attended previously. And I had a real good friend the first time she attended. She said she felt like she walked in and someone opened her brain and poured all the information in. It is a very intense week, but you leave, you know, stunned but excited and ready to, you know, take on EBP. But we also offer leading EBP. Teaching EBP is a brand new 2-day course that we're going to be kicking off in the fall. We offer systematic review workshops. And then we have the evidence-based practice certificate. So I will put the information in the chat. But know that we are here, the Fold, myself and the Fold representatives, we are here to support anyone who has questions about EBP and love to work with individuals. And we, you know, would love to work with any of you with an evidence-based practice question or problem.
All right, thank you so much, Cindy. So I have 2 questions. I would assume Mrs. Alexander may be able to answer the first one. It says, does the size of the institution affect the implementation of the best practice guideline at a healthcare institution?
No, it does not. If you remember what Mrs. Anderson-Johnson had said, that you identify or you have an inquiry in mind if there's an issue that you have and how do you go about resolving it. So it doesn't matter the size of the institution. If it is that you have an issue, you do a gap analysis, you find out what, you know, will affect or improve that issue, and you go ahead and you implement. The data is there. Evidence-based practice guidelines are there, so you can look at it and see what fits your context.
All right, thank you so much, Julianne. So Sheridan, I'd say she has a part 2 about what would we recommend for hospitals wishing to implement BPGs. I may take the liberty here of saying from all our presenters, 1, it has to be a team effort. There's no one person who could do it on their own. However, it doesn't mean you can't be that one person who starts the conversation. 2, I would suggest that we go to the RNAO site and look at the guidelines that they have and select maybe at least a guideline, 2 or 3 that you think could be implemented in your institution, because the guidelines also have information on the site about recommendations and how you could go about implementing. And thirdly, it would be great to have yourself and maybe a couple of your colleagues complete the best practice guideline champion training. So at least you're in a place already where you would have been exposed to what is necessary as a champion to do some of the implementing. And then I see that Ms. Brown may be able to help me with answering, and or she has a point. Kim?
Yes, thank you so much, Cheryl. I wanted to add to what you had suggested just now. Let's see, it's Sheridan Hardy. One of the most important things that you'd have to do is what we call like a gap analysis. So Julianne would have spoke about some of the data that would have really informed the choice of guideline that they implemented. So they had a problem with falls. Your hospital, if you're lucky, may not have a problem with falls. So you would not necessarily need, with any great urgency, to implement a falls prevention guideline. Perhaps your hospital sees a lot of patients who are abusing substances. And so perhaps a substance abuse guideline would be applicable. So it really has to start with an analysis of your own data, your own clients, and then you take it from there with a selection.
All right, and if I may be so direct as well, Sheridan, if Miss Brown or Mrs. Alexander doesn't mind sharing how you could find them, Professor Beckett has also shared her information and the full information, because that is also a way to have access to training. Since Miss Brown was the person who led the UWI School of Nursing, Mona, to becoming a best practice spotlight organization, and Mrs. Alexander is currently the lead on that at the University Hospital, they could also be possible resources to help you in the conversation or how to start it, because they would have done this, and it is a labor-intensive, extensive project. But from even the results we've gotten, it's obvious that it's something we can and should do to impact patient care delivery. So you may also be able to just reach out so that we could say, this is a great way you could start the conversation. But I would encourage you to do the analysis, see if you find your team, go to the RNAO site, look at the BPGs, and try to see if you find some persons to do the training with you to get started on your way. Thank you for your great questions. I believe Elizabeth Kimari, maybe you can help me here again after you've added on. So don't answer yet, let me just give you the question. Elizabeth is asking about if there are anything in the guidelines that may address the nurse to patient ratio, because this is a sore point. So you may go ahead, Kimari.
Okay, so off the top of my head, I can't tell you the exact name, but there are healthy workplace environment guidelines. So these are the guidelines that address those functional aspects of nursing. So I can do a quick search, but if my memory serves me correctly, yes, there would be guidelines that talk about best practices for staffing. I also wanted to add to my comment to Sheridan that if it is that you're interested in implementing guidelines and you go the route of formally expressing an interest to the RNAO to become a designate as a best practice spotlight organization, they provide a lot of support during the candidacy period and even after the candidacy period. So we've been designated since 2018 and we still have monthly check-in meetings. There's a yearly knowledge exchange symposium where previous to COVID, we would go in person and we would share our experiences and hear from others. So if it is you're interested, I would definitely suggest going that route so that you can have access to the resources from the RNAO.
Thank you so much, Kimari. All right, so I'm just double checking. Are there any other questions? Would anybody like to open their microphones and talk to us? Because everybody has been typing. I know a few of you may be shy, but we're just checking. Anybody want to open their microphones and just talk to us?
Okay.
Hi, Desmond.
Hi, sure. I am really excited. I don't have a question, but you asked
me. Take comments.
Yeah. I am really excited about what was delivered here this afternoon. I was introduced to evidence-based practice in 2018. Where we look at including evidence-based practice in the community. And every time I hear about evidence-based practice since then, I always jump at the opportunity to learn more. All right. I am excited about the opportunity to learn more from the Ontario
RNAO, just say RNAO.
RNAO, right, that's right. That is it. And I believe that as nurses, we need to take up our position. We need to position ourselves in the delivery of healthcare. I think we have been sitting back too much over the years, and we need to take up our positions. And these are opportunities that we have to really learn or discover how we can place ourselves in the forefront of healthcare delivery. And so I think this is our opportunity to do so, and we should very well take up that opportunity and move forward.
Thank you so much, Desmond. Thank you so much. I think we're all in agreement on that, because I think, as Sophia would have shared, that it was the fact that she could include and motivate and have nurses on board that was one of the pulling factors, and that we could be at the forefront of these initiatives that could definitely benefit patient care delivery and outcomes. So we want to just say that we are excited. In working towards what we wanted to achieve, we specifically chose to focus today on the practice guidelines and not necessarily on the BPSO aspect as yet. The UE School of Nursing, Mona, and perhaps University Hospital, we could look at having another session where they could share their journey with us, because it was a lot of work. But at this point, we're the only educational institution and clinical institution designated as BPSOs in the Caribbean, and we certainly want to expand and have more. While we're preparing our future colleagues, it's important that we have the clinical space for them to be able to see the guidelines in action. And so we really want to have more persons on board, more schools, more clinical settings, and so we're really grateful for that. So Sheridan, you're very welcome. We thank everybody. As we are closing off, remember I said I had a few questions to ask, and if anybody is able to give me the correct answers, then we would have a prize for you. So before I give you the questions, I'm gonna say again, we thank everybody for joining. If you are interested in CE hours, you need to have your full name, not your first or last name or nurse beside it, not your name of your phone, because some persons are logged in and may not be here. There has been some names of phones who have been here for the entire 2 hours. Those persons are not going to be able to get hours because I don't know who they are. Similarly, the registration link is in the chat. I'm asking persons to complete it there because we're not collecting any emails in the chat. That information should be provided on the registration form. So just a little bit of housekeeping. And if we are ready for the questions, there are 4 questions. Everybody's ready? Would you like me to read them out, or do you want me to type them in the chat before we close off? Any preferences? All right, maybe I'll read them out and you can write down your answers.
Read them out.
Wonderful. So I'll read them out, write your answers down quickly, and then you're gonna put your answers in the chat. Everybody's ready?
No.
All right, everybody needs to get a quick piece of paper so we can do the wrapping up. Get your little paper and your pencil really quickly.
I'm not ready, Cheryl.
You have time to get ready really quick, or you can use the notes on your smartphones to type.
Okay, go ahead.
Perfect. It's just 5 quick questions. Everybody's ready? 1, 2, 3, 4, 5. We're all ready? All right, let's go. Question 1. From the presentation from Mrs. Anderson Johnson, she gave us several EBP models, but she expanded on one particular model. What is the name of that model? I'm going to repeat. From the first presentation by Mrs. Anderson Johnson, she gave us several models for evidence-based practice, but she expanded on one. What is the name of that model? All right, question 2. From Ms. Brown's presentation, what is the other name that can be used synonymously for best practice guidelines? Again, question 2, what's the other name that can be used synonymously for best practice guidelines? Doing awesome, I can see everybody writing. Question 3, give me the name of one best practice guideline that was implemented by the University Hospital of the West Indies. Mrs. Alexander gave us 4. I'm asking you to give me any one from the 4. In fact, she gave us more than 4, but all right. All right, so just one from UE Hospitals implementation. Question 4. Professor Beckett gave us an example of evidence-based practice in action. What particular position in relation to COVID-19 did she discuss? So repeating, position that has shown to have maximum great benefits for the clients. What position did Professor Beckett discuss in her presentation for EBP? And question 5, what is the date? What are the dates, my apologies, for the upcoming best practice guidelines champion training by the RNAO? Question 5, what are the dates for the upcoming best practice guidelines champion training by the RNAO? All right, so everybody has had a chance to write their answers down. Now we're gonna see the answers coming out in the chat. So remember to put your 5 answers so we can determine the person who is our winner today or persons. So no more writing, I won't repeat the questions. I'm now waiting to see the chat popping with answers.
Are the presenters allowed to participate?
No, they're not. No, Miss Brown. All right, so we should see the chat popping away, popping away, popping away. Wonderful. I'm going to ask the presenters to help me to pick the winner. So there are 5 questions. We're expecting 5 answers from each person. Wonderful. I'm giving you another minute to go ahead and do your typing in the chat. And I'm counting down that 60 seconds and then we will not be accepting any answers. All right, going. Just a little bit more. All right, so I think our minute is up. So I'm going to ask that we have no more typing. All right, so do we need 20 more seconds? Because some persons are putting their answers one at a time. Persons, you're confusing us. Why didn't you put all your answers at once? All right, so let me ask my colleagues who presented, can you help me to verify in the chat if we have a winner? All right, so Desmond was quick on the draw. Wow. All right. So let me ask.
Just a little clarification, Cheryl, for my
Yes.
answer. I was typing and 2 things came up one time. So practical and practice, but it's practice. So delete the practical, just practice from a second.
All right, perfect. So let me start off at the beginning. Madam Pauline, could you tell us what was the model that you expanded on, please? So I want persons who typed and who didn't get to type to listen. Madam Pauline, can you tell us what's the name of the model you expanded on? Pauline, are you talking to us muted again?
I can confirm that it was the ARC model.
It was the ARC model. Thank you so much, Cindy. ARC. That was the model that she spoke to us about. All right, so that's question 1. Miss Brown, can you tell us what's the synonymous name for the best practice guidelines?
Clinical practice guidelines.
Clinical practice guidelines. Perfect. Mrs. Alexander, can you tell us the BPGs that you've implemented at University Hospital?
Sure. Prevention of fall and fall injuries in the older adult, and we have upgraded to preventing falls and reducing injury from falls.
All right.
There is assessment and management of pressure injuries for the interprofessional team, professionalism in nursing, and have I given you all of them?
I think so.
Yeah.
All right, wonderful. And Cindy, what position was it that you spoke to us about in your presentation?
It was early proning.
Early proning. Thank you so much. And then the dates for the upcoming BPG champion training are August 10th and the 17th. So I want all of you who typed to tell me, are these the answers you have? Did anybody say the ARC model? So you make sure you have all 5 right, you know? Clinical practice guidelines, prevention of falls, professionalism. I'm listening to Julian, and of course, you know, I've forgotten some of what she said. It was early proning for the position, and the dates are August 10th and 17th. So I think we have some people on the ball with some of the answers, but do we have somebody who has all of them correct? Because I'm not sure anybody gave us early proning for the position, and that may be the only one. And we had a few people who gave us the ARC, but they added another C. Right, so.
It is actually ARCC.
All right, thank
C's.
you. That's 2 C's.
Yep.
All right, great. Did anybody give us early proning? Because that's the only one I think I didn't see. No? Anybody? Did anybody have early proning?
We have prone.
Okay.
Or
So other
proning.
persons have prone. All
Prone,
right, so.
Prone
with
is
that-
the position.
Pronin.
Perfect. So with that being said, I want you, if you can, open your microphones, give yourselves a very big round of applause. I could see the brains and the hands working overtime to write and then to type. And I want to thank you for answering almost correctly, all of you. Desmond and Karen, they said you were presenting, you were part of the group today, so you don't qualify.
No, I didn't have any advantage over anybody, really. I was a participant just like everyone else.
You said you were actively listening, Karen. I'd agree with that.
I said so, Karen.
So I would want to thank all of you so much for participating actively. You were awesome. Remember, we're looking at the ARCC model. That's one that we could easily use. Clinical practice guidelines or best practice guidelines. If you search, you'll find both of those. We looked at the updating for the prevention of falls. It's now changed, and that one in particular, they've gotten awesome results after implementing that from University Hospital. And I think the last one I would have heard was the professionalism one as well, because we are realizing we are in the media a lot, and that's something that we perhaps need to really look at implementing. And so Prof. Beckett gave us the example. They've looked at the information and all the work and looked at the fact that early proning has been proven to have awesome results for persons who are diagnosed with COVID. And for persons who are interested, the link was shared in the chat for the RNAO site. Go ahead and get yourselves registered to complete your BPG champion training. It's virtual, it's free, and they'll email you your button to wear proudly when you've completed your training. I want to really express on behalf of the Omega Kappa chapter of Sigma, a very huge thank you to our presenters who all gave up their time today, to Mrs. Jones-Fraser for helping me throughout the session, to all of you for joining us and actively participating, but not just for participating, but being a part of the future that we want to envision, and the fact that we want to be the nurses who are leading. So I will implore all of you, go to the site, look at the BPGs, see what you'd like to implement, reach out to Ms. Brown and Mrs. Alexander, I'll put their contact in the chat as well. Look at the training and getting some people on board, and look at reaching out to the RNAO as well, because they provide great support. Prof. Beckett also put the information for herself and for the full information, because they too offer training and assistance with looking at evidence-based practice and guidelines. And I'm really hoping that our ultimate goal will be that all of us here will take away from this session today, going out to apply what we've learned so that we can be leading from the front and being a part of the healthcare we're trying to envision. I thank you all so much. Thank you for staying with us. And I'm going to say lastly again, before we all go, can you please ensure you're registered, because we won't be able to find you otherwise. That's where your information should be. So I know that We don't want the noise, and we have the emoji to do the clapping. But Mrs. Marshall Davis, are you still with us? I'm not hearing her. And since I'm looking in the chat before we go, we were streaming the session today on our YouTube channel. So any part you've missed, if you go to YouTube and search for the Omega Kappa chapter of Sigma, you'll be able to catch the presentation from the beginning. Thank you, Mrs. Marshall Davis. I just wanted to give you the opportunity to do a final thank you before we all leave. I'm calling on you suddenly, but I know you're good.
Okay. Okay. Well, indeed, this was what you would call an invigorating afternoon. Thanks to the presenters. You know, I really feel enthusiastic, especially as it relates to the university and the Bellevue Hospital, who even that departmental sister has just gotten trained, yet still she put her best foot forward. So thank you for all the presenters. I'm not able to call all the names, but the presentations were great. The audience or the participants, I really enjoy looking at the various comments coming into the chat. And so thank you all. Thank you to the team who put this together and went sure. I know it's not easy work, so thank you one and all. God bless you. Keep safe and enjoy the rest of the evening. Bless you.
Thank you so much, Mrs. Marshall Davis. And with that, we say adios or adieu or goodbye.
Thank you.
Bye.
Bye.
Thank you so much, Prof. Beckett. Thank you.
Happy to be here. Thank you so much. Bye-bye.
Bye. Thank you, Prof. Beckett, and we will be talking.
Thank you. Have a good evening, everybody.
Bye, everyone.
Happy
Bye,
anniversary,
Cheryl.
Jude.
Thank you. Bye-bye.
Bye.
Judy Ann, wonderful. Kimari.
Bye, Mrs. Anderson Johnson. Kimari, we need to talk.